Hi guys, welcome back. We shall now be talking regarding basic life support. In this program, we will learn regarding what is the out of the hospital care that we will be providing to any person who has suddenly become unresponsive and pulseless and BPLess. In Western countries, it is mandatory for everybody to attend a BLS program, and in our country also gradually this is picking up. So if you guys have attended any BLS program, if you've conducted any program, or if you have attended the program yourself as a student, you might be having non-medico students with you. You might be having a housewife who's like, let me say, 60 years of age. She's not even having a science background, and she says, doctor, my husband had a cardiac event 2 weeks ago. She does not know what MI is, what arrhythmias is. She just says that my husband, he just clutched his chest and he fell down, and he was not even breathing properly, and I did not know what to do. So she was just freaking out, and she says that since my husband is now a cardiac patient, I wanna learn what is to be done if this happens to him again. So out of hospital care that you provide from the cardiac perspective for ensuring circulation of the patient, airway of the patient, breathing of the patient is what basic life support all about. When we try to evaluate how effective this procedure is, they have measured regarding the success of this program in Western countries. They have demonstrated the fact that if a person is having any cardiac event which is occurring out of the hospital, it could be any cardiac event, it could be asystole, pulseless electrical activity, VT, ventricular fibrillation, whatever, but at least CPR was provided to the patient. So they have calculated that for any cardiac event that occurs out of the hospital, the chances of survival of the patient are close to 10%. In Western countries, why that survival is still close to 10% is because the ambulance will reach the hospital, will at least reach first the patient on time, and then will reach the hospital on time, and obviously they will make way for ambulance, unlike in our country. So survival rates are still in the range of about 10%, and they have also documented the fact that if a person had a cardiac event, and even before the ambulance came, because if there's a possibility that somebody calls 911 number in America, the ambulance might take 4 minutes, 5 minutes, 6 minutes to come, and brain usually dies within 4 minutes on loss of circulation. So if a person is having a cardiac event which is occurring out of the hospital, and the person was provided a bystander CPR, then the ambulance reached, and then the medics took over the case and they transported the person in the shortest possible time to the hospital, the survival rate of the person dramatically increased to 20%. So you can see a straightaway jump of 10% of ensuring survival of a person when the CPR was provided even by a non-medical person, like a bystander on the beach. The person was drowning and the person provided CPR, and the survival chances of the person have increased. So that is why basic life support, because of the success of this program, it has become important that anybody and everybody should be learning about this procedure. So before we learn about the steps of basic life support, we need to understand what do you mean by the word cardiac arrest, because I'll be using this term multiple times. One of the first and the foremost things in cardiac arrest is that the person will become unresponsive because there will be no cerebral blood flow. You will not be able to get any pulse in the patient. The pulse that you will check in the patient will be carotid. Why? Because it is closest to the heart and it will be the last one to go. I mean, if a person is having any condition like shock, first peripheral pulses are lost, then carotid artery pulsation will go. The person will also develop lack of breathing effort, that is apnea, or there might be gasping respiration in the patient. These gasping respiration might be agonizing for both the patient as well as for the relatives to watch, so it is called as agonal rhythm. So 3 things should be demonstrated for presence of cardiac arrest, and if this happens outside the hospital, if a bystander is even giving a CPR, the survival chances of the person is definitely increasing. Please appreciate the fact that when it comes to a pulseless state, the reason why a person could become pulseless could be either due to arrhythmia by the name of ventricular fibrillation or due to ventricular tachycardia, or it could be secondary to asystole, a flatlining of the ECG in the patient, or it could be due to pulseless electrical activity secondary to conditions like cardiac tamponade and tension pneumothorax. The left hand side, ventricular fibrillation and ventricular tachycardia, are technically called as shockable rhythms, and the survival chances of a person with ventricular fibrillation and ventricular tachycardia is higher. Why? Because straight away you need to do cardioversion. So since you know that in this condition cardioversion is definitive treatment, so the survival chances will be relatively higher. But on the right hand side, the survival chances are definitely lesser, and we do not shock. Remember my words, we do not shock a flatline ECG, or we do not shock a pulseless electrical activity. So, though in a very, you would have noticed that in television serials, like even Grey's Anatomy, person is having a flatline ECG and they're giving DC shock, but DC shock does not work on a flatline ECG. Even if a person is having a pulseless electrical activity, where a person is having this broad complex QRS secondary to hypothermia, you would still not shock the patient because the motor is working. The pulse is not there because ultimately heart is not having sufficient oxygen, so the contractility part is compromised. Ventricular fibrillation will be just twitching, and ventricular tachycardia would be having this broad complex QRS present, which would be very easy to pick up. And therefore, once we have understood shockable and non-shockable, it will become relatively easy for us to understand the protocol. Please remember MCQ wise that it is not a hard and a fast rule that person of ventricular fibrillation will not become a asystole. There is a possibility that initially person at ventricular fibrillation then gets converted into asystole, and there is also possibility that asystole patient, when you give epinephrine to the patient or adrenaline to the patient, secondary to adrenaline he can start developing ventricular fibrillation. So you will have to continuously jump from left to right and right to left. So there is no hard and fast rule that if ventricular fibrillation is there, it cannot get converted into asystole, and vice versa. Both of these swaps are possible, so we need to keep our mind open for that. Now I'll give you a case which will help you understand the steps of basic life support relatively better, and the steps would be in the following fashion. Let me say you are a doctor, you are flying to attend a conference, and you are at the airport at a boarding gate when an elderly gentleman, like the announcement for flight was made, and there's an elderly gentleman, he's, let me say, about 60-70 by age group. By the appearance of the person and the gait of the person, you estimate that this elderly man is about 60 to 70 years of age. He was standing in the queue ahead of you because the announcement for flight was made and you were getting ready for boarding. So this elderly man is about 60 years of age. He has collapsed suddenly. Just without warning, the old man collapsed suddenly, and suddenly there was a lot of commotion going on, and there was an announcement saying any doctor available, and you as a responsible person, as a responsible doctor, volunteered for help. So MCQ wise, they'll ask you what is the steps to be taken by you. So don't straight away answer check pulse, because that is the first impression or the first answer that most people give. Your answer here would be check scene safety. You see, please appreciate the fact that this gentleman, when he has fallen, he could have fallen near electrical cables, and there's a possibility that he can get electrocuted. Or let me say he fell down near an escalator, like at airports there are multiple escalators. He fell down near the escalator, he can get injured by the escalator, or he fell very close to the escalator, so people who are walking on the escalator could also topple over him. So what I'm trying to say here is that first I would like to move the person to safe ground, that is on a smooth and a flat surface, so that the chances of electrocution or him injuring somebody else or he getting injured by somebody else is minimized. The next thing I will do is tap on the shoulder of the patient, call him out by his name if I can read the name of him on the boarding card. If I don't have the boarding card, no issues. I'll still say, sir, can you hear me? So after checking scene safety, you have to go for the next step, that is to check for unresponsiveness of the patient. And unfortunately, this old man, his eyes are closed and he did not open his eyes to the stimulus that you provided on the shoulder. In these circumstances, you will call for help. Now, for call for help, I do not mean that you would scream your lungs out. Obviously, I'm not saying that. But you would just ask politely that if anybody else has taken BLS training, the person can help you on. Because if you have more hands at your disposal, it will be relatively better. You see, why I'm saying call for help is important is also because of the fact that you anyway need an automated external defibrillator to check out the rhythm, because I'm going to find out whether it is shockable or non-shockable. And if it is shockable, then we can definitely manage the patient relatively better. So I will have to send somebody to fetch an automated external defibrillator. Most of the times at metro station, at airport, almost at every boarding gate, it is mandatory to have a AED present, an automated external defibrillator. So if you are observant, you would have noticed multiple times a container which is marked all red, and in fact, they might be having this sign of the heart with the electrical symbol in between, saying very boldly AED, automated external defibrillator. You just need to, turn on the lock, take it out, and then deploy it on the chest of the patient, and you can pick up the rhythm, and then you can definitely improve the chances of making the person survive. I can just give a real-time example. Recently, there was a video viral on YouTube at Delhi airport. A person just collapsed just like that, and the CISF constable who was at the boarding gate. The job of the CISF constables is obviously to prevent any terrorist attack, etc. But the CISF constable who was trained in basic life support, he first gave CPR to the patient, and after giving CPR, he attached the AED to the chest of the patient, and luckily it was a shockable rhythm. So he pressed on the button, and the computer delivered a DC shock, and the person recovered. So why I'm telling you this is because if a 10th pass or a 12th pass person who is working as a constable in a CISF can do this job, you and me can do it much more better and with much more technical finesse. So I will call for help to just let people know if somebody is available, they can help me out. Great. If not, I will be the only one who will be the boss or will be handling this situation. The next step is activate emergency response. Now, point number 4 is more valid for American scenarios where you might be having to call up a number like 911, or like in India calling up 108, or so many other services government is launching now. Apps are available, etc. So, I mean, gradually the technical or the tech savviness of Indian people is also increasing. So, various protocols are being instituted. So, activate the emergency response would be the 4th step for you to answer in the MCQ, and mostly because they're asking the American protocol, so we'll just mention the word activate emergency response. Assuming that you're working in an Indian setup which is having scarce resources, obviously point number 4 has no sense for you, but you will now have to go in for the next thing, that is that you will have to check the pulse of the patient. One person has already gone looking for an AED on your advice, that is the person who you called for help, and you are at the moment evaluating the carotid pulse of the patient. You are evaluating the common carotid artery of the patient, and simultaneously you would check for breathing effort. How would you check for breathing effort? You can look at the chest movement of the person, you can look at the rise and the fall of the chest, you can bring your face close to the face of the person to feel the breath of the person from the nostrils, from the mouth, and in case you find that there is no carotid pulse and there is no breathing effort, that definitely means the fact that your person is a candidate for a CPR. I'm just writing in short form, the pulse is not there in the patient and the breathing efforts of the patient or respiration is also not there in the patient, then the person is in cardiorespiratory arrest, and in these circumstances CPR is to be instituted. But another possibility can be that the pulse in the patient is very much there. It is just the fact that the respiratory efforts in the patient are absent, then the person is only in respiratory arrest, and you need to take steps to manage only the respiratory arrest component of the patient. What I mean by managing the respiratory arrest is that in this case, you just need to provide rescue breaths to the patient only, and these rescue breaths will be provided at a rate of, let me say, about 1 every 6 seconds. So rescue breaths that are to be provided to this patient are in the range of 10 to 12 per minute. That would mean approximately 1 breath every 5 to 6 seconds. But if the person is having absent pulse and absent respiratory breathing effort, then it is CPR that is to be instituted at a rate of 30:2. They've asked in the exam what is the duration for which CPR should be given, then the answer would be for at least 2 minutes. One cycle of CPR is at least for 2 minutes. The last possibility in the patient is that the pulse is very much there and the breathing efforts in the patient are very much there. This means the fact that this person does not require any CPR. There's a possibility that he could be a diabetic, and because of hypoglycemia he lost consciousness and he fell down, so there is no role of CPR. So in this case you will just monitor the patient in a sense that you will wait for the emergency response of the airport to kick in, because obviously there is a doctor stationed at the airport from various hospitals, etc., who would be responsible for then taking the transfer of the case from you. You are anyway going to go and board your flight, but do remember that if your flight is boarding at that particular point of time, you are supposed to stay back with this patient till you take a transfer. And there have been instances when doctors have been negligent in this, and then they had medical legal cases registered against them. So if you are stuck up in a situation like this, then obviously you have to follow what we say as the Hippocrates oath. When we took the Hippocrates oath, we have declared that come what may, we will stand by the patient. So this is one example, like you are missing a flight, but still you will have to stay by the patient before the medical team of the airport takes over the transfer of the case from you. The basic steps to be understood in this particular protocol are, and I'll repeat the steps once again, is check scene safety, then evaluate for unresponsiveness, call for help, and then check for carotid pulse and the breathing efforts. And if the person is pulseless, there is no breathing efforts in the patient, then CPR in the patient has to be instituted. And once the CPR has been instituted, then by that time the AED will also be available. Now I'll just mention regarding the AED part in this particular slide only. Once the AED is available, like you have given CPR to this person for 2 minutes and AED is available, you will attach the AED electrodes onto the chest of the patient. When you attach the AEG electrodes to the chest of the patient, the AED is a computer that will read the rhythm of the heart. It will verbally say, there's a talking software that will say that whether it is a shockable or it is a non-shockable rhythm. If it is non-shockable, obviously you will continue with CPR and transfer the patient to the main hospital as early as possible. But if it says shockable rhythm detected, then you just need to press on a button and it will deliver a DC shock of 200 joules, which will reset the rhythm of the heart, and it will get the rhythm of the heart back to normal, and there can be a return of spontaneous circulation. And how would you know circulation is back? You can get a carotid pulse in the patient, and you will notice the fact that you might be able to maybe get even the breathing effort of the patient back to normal, because the blood supply to brain is reestablished. So the brainstem is getting the blood supply, so the breathing efforts will restart in the patient again. Though the earlier you do this, the better. Shockable rhythms are ventricular tachycardia and ventricular fibrillation. So that's the basic aspect that you need to do for basic life support. Now, when it comes to chest compressions in a patient, you can notice the way a doctor is giving chest compressions in an adult patient. I have already told you that the ratio would be 30:2. The number of chest compressions to be given per minute is between 100 to 120 per minute. A doctor is supposed to give 2 chest compressions every 1 second, so 16 to 2 would be 120. So the rate of chest compressions would be 100 to 120. The sternum should go down by approximately 5 centimeter. You must allow for proper recoil of the chest, because why the recoil of the chest is important is because you also need to allow the heart to get filled with blood. Because if it will get filled with blood during diastole, coronary blood flow will be ensured. So unless and until you ensure coronary flow, the survival chances of the person will definitely be minimized. So if you are over enthusiastic in giving chest compression and do not allow recoil of the chest, then the coronary blood flow of the patient will definitely be compromised. You can notice the hand of the person on the lower 1/3 of the sternum. If a doctor is pressing too hard on the lower 1/3 of the sternum, there's also a possibility that he might actually press on the Xiphi sternum, and because Xiphi sternum is pointed, it might result in trauma to the liver of the patient. So one of the solid organs that is traumatized in CPR happens to be the liver of the patient. I repeat my statement again, the common solid organ traumatized in CPR is not the lung, because lung is not a solid organ, it is liver that is traumatized. And when you are giving a bystander CPR in the patient, you will notice the fact that you have to lean on to the body of the patient. The weight of your head, neck and chest is sufficient to depress the sternum by 5 centimeter, and the fulcrum that you will be using will be your hip joint. That is, you need to just move forward and backward. The fulcrum would be at the hip joint, and the elbows of yours should be straight, and you should not flex your elbows. It's very clear that if you will flex your elbows like this, there's a possibility that the power of your back muscles like latissimus dorsi will be added, that will break the ribs of the patient. So usually the ribs that can break can be either 4th to the 6th ribs. Even if the ribs will break, you will not discontinue CPR. So there is a possibility that if you are giving too enthusiastic CPR in the patient, then the possibility of rib fracture will be there, but the CPR part is not to be discontinued in the patient. The upstroke and the downstroke motion should be having a fulcrum at the hip joint. Most of the time the ribs that are fractured are 4th to the 6th ribs in the patient, and do not discontinue CPR even if the ribs are fractured. The first and the foremost thing for management of any patient once the CPR part is instituted is circulation, that is chest compressions, followed by airway. For getting the airway, obviously the older way is mouth-to-mouth resuscitation, but here we are having a medical facility where a mask is available with an ambu bag. So when I will resuscitate this patient using an ambu bag and a mask, you can see that the doctor will be ensuring the airway of the patient. In ensuring the airway of the patient, 2 things have to be done. One is head tilt, and second is a chin lift. This will just ensure the patency, head tilt and a chin lift, that will ensure patency of the airway of the patient, so the air can go better into the lungs of the patient. Subsequently, you can secure an advanced airway. That is, you can use an endotracheal tube or you can use a laryngeal mask airway. But at the moment, for providing the airway of the patient, if you just provide a head tilt and a chest lift, the chances of you ventilating the patient will be definitely better. Look at the hands of the doctor. The thumb and the index finger are forming a semicircle or a C so that they can ensure that the mask is tightly fitted to the face. So I'll just highlight alphabet C here to highlight the thumb and the index finger, that is the left hand thumb and the index finger, are ensuring the fact that a proper seal is formed onto the face of the patient, and the remaining three fingers of the patient, these fingers of the patient are on the lower part of the mandible of the patient and on the chin, so that you can achieve a chin lift in the patient. So I'll position the hand in the right way. One, the thumb and the index finger is securing the mask, and the remaining three fingers are supporting the mandible of the patient, the middle, and then the chin of the patient, so that a chin lift can be done in the patient, and the head is obviously extended slightly in a sniffing position, I would say. This will ensure a better airway access in the patient. After that, breathing has to be done. For the breathing part, you need to count. If you are the one who are giving the breathing part, you have to count 1001, 1002, that is two breaths, then your friend would be giving CPR. And most of the time, because one cycle of CPR is for 2 minutes and it is tiring, so it's a possibility that after one or two cycles, if you're tired, you can swap position with your friend and you can go to giving bagging of the patient. You can go to doing ambu bagging of the patient, and your friend can take over and take the responsibility of giving chest compressions. If you are the team leader, you are supposed to stand at the foot end of the patient. Like, let me say, if the patient is lying on the bed at the moment, so one doctor will obviously be placed securing the airway in the position that I said, hold the face mask to the patient, ensure a chin lift in the patient. You will be the team leader who will be standing at the foot end of the patient to give clear instructions to the patient. On the right hand side of the patient, you would be having a team which would be at least 2 or 3 doctors who would be standing in a queue to give CPR. Why I'm saying 2 or 3 doctors or paramedical worker can be there to give CPR? Because usually you get tired very soon. So it's a good idea to change the team member after every 2 minutes of chest compression. On the left hand side, you will be having a nurse who would be then, or a doctor who would be ready to secure a IV line in the patient and take blood samples of the patient. Blood samples would be like ABG of the patient or electrolytes or complete metabolic profile of the patient. So the coordination between the entire team should be good so that you can ensure a better survival of your patients. Let's have a quick recap of the adult BLS algorithm. The first step is to establish scene safety, where the chances of injuries to the patient have to be minimized and the person should be on a flat surface so that a proper CPR protocol can be initiated. You would shout for help because more hands at your disposal will ensure better survival of the patient. You can use this person initially not for giving CPR, but ask the person to procure the automated external defibrillator. So at the railway station or at the airport or any other public convenience site, there might be a doctor's chamber available where AED may also be available. So the chances of getting a AED and then ensuring survival of the patient will increase. Meanwhile, you yourself will check for the pulse and the breathing effort of the patient for a duration not more than 10 seconds, and assuming that no pulse and no breathing effort was seen in the patient, so you will initiate the CPR cycle in the patient. One cycle of CPR will last for a total of 2 minutes, but even before the CPR cycle could get over, the person has returned with the AED. As soon as the AED machine is available, you will not wait for 2 minutes for the CPR cycle to get over and then initiate or put the electrodes of the AED. You will use the AED immediately upon arrival. That is, even if the CPR cycle is not complete, you will interrupt the cycle and deploy AED electrodes so that you can differentiate a presence of a shockable and a non-shockable rhythm. Remember that AED, the electrodes have to be positioned in such a fashion that one of the electrode has to be placed below the right clavicle and superior to the right nipple, and one of the paddles has to be put just covering the left nipple and going into the axilla, and it will fire a DC shock of 200 joules biphasic. Don't bother about monophasic and biphasic, because most of the time in older books when I was at your age, I used to read 360 joules monophasic. Now, difference between monophasic and biphasic is like that of AC current and DC current, like you study in physics. So don't get bothered by that. Just remember, all the AEDs that are programmed at the moment are programmed to fire at 200 joules biphasic only. This computer will read the rhythm and then it will say verbally, shockable rhythm detected. You just press on the button, it will deliver a DC shock, and when the arrhythmia will be terminated, it will reset the cardiac rhythm of the patient. I've highlighted time and again before you that if a person is having a shockable rhythm, that is ventricular tachycardia and ventricular fibrillation, then the chances of survival of the patient is definitely increased. But if the person is having a non-shockable rhythm, which could be from asystole or pulseless electrical activity, then specific management for asystole in the form of epinephrine, or for pulseless electrical activity, find the reversible causes, that is the 5H and the 5Ts that I have discussed in the PEA topic separately, have to be evaluated so that you can manage on a case specific basis on the patient. I would also like you to remember the fact that in adults, whether one doctor is available or two doctors are available, the ratio of resuscitation would remain the same, that is 30:2. If they ask you the same question in pediatrics and they ask you that what is the ratio of CPR administration in a child, and he says that you are the only doctor on duty, that is, you are the single rescuer on duty, then the ratio would be given by you as 30:2 for only one doctor on duty. But suppose there are two doctors on duty, then the ratio will change is to 15:2. So do remember this fact that for adult, irrespective of the number of rescuers, it will be 30:2. And when it comes to a child, then it will change depending upon the number of doctors which are available for taking care of this particular patient. With respect to neonatology, it is mandatory the two doctors should always be available, and the resuscitation protocol would be 3:1. So this is one very easy aspect that has been asked a couple of times in the exam, and that's I would say most of you are already familiar of this. The magnitude of sternal depression should be 5 centimeter for adult, it should be 2 centimeter for a child, and it should be 1 centimeter for a neonate. Though you can refer to the pediatric guidelines better for this, but I would still like you to remember this data for the magnitude of sternal depression in the patient. And I would just like to, in the end, mention regarding the fact that why is it that a person had requirement of CPR, or why did the person become pulseless and BPless? What really happened? So the leading cause of why a person can develop a sudden cardiac death, or can develop a cardiac arrest, or can develop arrhythmia is mainly because of coronary artery disease. So that's one of the primary killers in the world at the moment. But not all patients would be having coronary artery disease. So some patients could be having cardiomyopathy, and this cardiomyopathy could be like hypertrophic obstructive cardiomyopathy, Takotsubo cardiomyopathy, and this is a recipe for disaster because it can initiate arrhythmias, and those arrhythmias can contribute to definitive possibility of pulseless and BPless state in the patient. Then could be valvular lesions in a patient. Valvular lesions like aortic stenosis can contribute to left ventricular hypertrophy and ischemia in the heart. It can trigger MI. But if a person is having valvular lesion like mitral stenosis or mitral regurgitation, then it will cause left atrial dilatation, which will trigger atrial fibrillation, and atrial fibrillation can contribute to stroke. So lots of time you might have an unresponsive patient. Why? Because he's having stroke, but his pulse is fine and BP is fine. So remember, I was talking about the fact that there is a possibility that the person has become unresponsive because there is damage to the parietal cortex, the temporal cortex of the patient. The left middle cerebral artery is blocked due to clots from the atrial fibrillation, but his pulse and BP would be fine. Then you don't need to give any chest compressions in that patient. You have to thrombolyze the person if he's having ischemic stroke. The fourth reason why it can happen is secondary to bundle branch block, which could be secondary to MI, or rare conditions like a channelopathy by the name of Brugada syndrome. It's a sodium channel defect which again predisposes to development of torsitis de pointes or polymorphic ventricular tachycardia. In this person, again, due to the fast beating of the heart, he will become pulseless and BPless. Electrolyte imbalances are always to be remembered from cardiology perspective, mainly hyperkalemia. So if you're having a patient with a dialysis catheter in place, or a known diabetic nephropathy patient coming to you, he is regularly attending your dialysis clinic and today has been brought in a pulseless state, you know hyperkalemia is the reason why he had a PEA event. Then could be obviously toxins. A person might have had some issues in his personal life and he consumed TCA overdosage can contribute to this, or any toxin per se. It could even be organophosphorus poisoning. It could be a combination of heroin with alcohol, with multiple, with snorting of cocaine. So I mean, various drug overdosage could also contribute to finally a person developing a pulseless electrical activity. So all of these are usually reasons why people suddenly deteriorate, and your job is first to manage the patient, to ensure circulation, airway, breathing, defibrillation. So now we call it CABD, that is circulation, then is airway, then is breathing, then is defibrillation, and these are the reasons why this would be happening in the patient. Most of the time they will simply ask you the steps. So if you just go through the steps that I enumerated here or I enumerated initially, you would be on your track to answer these relatively very easy questions. And I personally feel that BLS is one of the easiest parts for any doctor to answer, and we have been trying to teach this to non-medicals now. So the chances of at least cardiovascular mortality can definitely come down in our country, and that's one of the big killers in our country. So we can hope that with awareness, with education, people will rather start understanding the doctors are not magicians, and they need to assist us in ensuring that a person reaches the hospital on time. Because most of the time in India nowadays, the impression is the doctor did not take proper care. That is why, you know, the violence part comes in. That's because of lack of education, whereas they themselves could have done some steps to ensure that their dad or granddad did reach the hospital on time, in a sense that he received some basic medical care. So we would be in a better position to manage the patient, because at least if some circulation to brain is maintained, if some circulation to heart is maintained, we can at least try to ensure that this person lives. We obviously can't guarantee that, but basic life support, as I told you, has increased the chances of survival dramatically. That is why they have decided that non-medicals or ordinary people should be taught about it, because otherwise in our field everything that we learn is for what we should do. We don't go and educate ordinary population, but this BLS is something which is to be percolated down to the lowest level or all levels of the society, irrespective of the age group, so that we can have as a community a decreased burden of the disease. Thank you so much for listening.